Good afternoon. My name is Celeste Newby. I'm an assistant professor in the internal medicine department at Tulane School of Medicine. So I'm a physician, and I spend most of my days training residents and students and seeing patients. The second panel, we are going to focus on physician and nursing pipeline issues and workforce labor supply issues. With that being said, we do have some set questions as we did for the first panel, but really we want to open it up to our experts to discuss whatever they think is most relevant. So we'll start with some questions, but then we'll let them take this conversation where they think it needs to go. So I'm going to allow each of our speakers to introduce themselves and share their job title and expert area of research, and then we'll start the questions.
All right. Well, thank you so much for having me here. My name is Bianca Frogner. I'm a professor in the Department of Family Medicine at University of Washington in Seattle. I direct the Center for Health Workforce Studies there, and I direct the Primary Care Innovation Lab. So my areas of expertise is around health workforce broadly across all different occupations, because we focus a lot on the allied health workforce, which I'm happy to go into more, but glad to be here today.
I'm Candace Chen. I'm a primary care pediatrician by background, and I'm an associate professor at the Fitzhugh Mullen Institute for Health Workforce Equity. So what we really concentrate on is what the intersection is between health workforce and health equity. And my work is probably focused mostly on the physician workforce, and I also spent a couple years working at HRSA, running some of the grant programs and the residency training program, payment programs out of HRSA.
I'm Michael Tuddy. I'm Group Vice President of Professional Satisfaction and Practice Sustainability at the American Medical Association. I lead one of our three mission areas focused on making physicians happy and financially stable.
Hi everyone. I'm Alice Chen. I'm the Vice Dean for Research and Associate Professor at the University of Southern California, the Sol Price School of Public Policy. My research is on the supply side of healthcare, so a bit broader than just physician workforce, but I think about physician labor supply in addition to sort of physician incentives.
All right, thank you all, and so glad we can have all of you here with us. So we're going to open this up to the whole panel, whoever would like to jump in, but the first question that I would like to have you weigh in on is, what do you think the most urgent issue is at this time to improve the healthcare workforce shortage?
Well, what's really great is I'll start off is the fact that there is a lot of attention on the health workforce right now. If you're not aware already, the Senate Health, Education, Labor, and Pensions Committee has taken up health workforce as one of their primary issues in this legislative year. The Senate Finance Committee has also taken a lot of interest in health workforce issues. So if anything, finally, we're actually having a discussion. What I would love to see happen in this upcoming year is attention to the full spectrum of the workforce. So really taking into account that when we talk about team-based care, we need to talk not just about our physicians and nurses, but also our medical assistants, talk about long-term care as well as primary care as well as acute care.
I think one of the things that happens when we focus on the health workforce and health workforce supply is often the immediate kind of knee-jerk reaction is let's increase training and let's increase production. And therefore we will increase supply. But I think even before COVID, we were having a real issue across the workforce, unfair wages and challenging work conditions, throughout. And then a real challenge of rising burnout and moral injury across the workforce as well. And then COVID happened, and it kind of like put the pressure cooker on and like turned it all the way up. And so a lot of time I think we talk about the workforce being like a leaky bucket. And then COVID kind of came in and just basically punched a bunch of huge holes into that bucket. And as much as we should be thinking about producing, I'll say, more of the right kinds, we also really need to think about how do we stop driving people out of the healthcare, out of the health workforce, and maybe even get some of those people back that have left.
And that's exactly right. I was going to say the same thing. You know, I think we know what to do to get more people into the healthcare workforce. I mean, we're not doing all the things we need to do by expanding the pipeline, but I do worry whether that be a medical assistant who went through a 6-month training program or a physician who went to undergrad medical school and 10,000 hours or more of residency, leaving the profession altogether, leaving clinical care to find other opportunities. particularly at the low wage scales, at $15, $16, and $17 an hour, which a lot of the healthcare system is running on people making $15, $16, $17 an hour. We're not competing a health system with another health system. You're competing with fast food. You're competing with retail. You're competing with the Amazon fulfillment warehouse. And we have a workforce shortage, period. So healthcare is now competing with other types of sectors who are going to start to increase their wages because they're trying to find workers. And if you're making $16 an hour, even if you went through a 6-month training program to be a medical assistant, and someone offers you $1 more an hour, that's meaningful take-home pay, and you'll leave because healthcare is hard. It's hard work.
So I agree with what my fellow panelists all said, but one thing that has struck me is just looking at the impacts of COVID and which sectors of the healthcare workforce have kind of gotten back. And the one that is still declining is nurses working in nursing care and elder care facilities, and that's the one that worries me the most.
Michael, you mentioned that we know what to do, but we're not doing it. Maybe you could talk a little more about that, since we're hoping for innovative solutions to these problems.
Well, you can look for physicians, where I've done most of my research. You can look at, for the last 10 years, we've increased the number of medical students, both by new medical schools, both MD and DO. Many and most medical schools have increased their class sizes, so we are creating more medical students. We've increased residency spots. The match was this week. If you looked, we had the most spots, yet there's still people who aren't getting a match, so we need to do more. We talked earlier about where those are located in the previous panel and making sure we're getting residency spots in the right specialties and right areas, but we need to do more in that area as well. But those are problems that at least we know how to solve them, right? We just need to invest some more money in them. But once people are in the workforce, how do we make sure we keep them there? Because today, there's more competition, and even physicians who may feel like clinical care has been their sole training and purpose can find career opportunities outside of delivering clinical care. But we need everybody who's been trained to stay in clinical care. And while those individual decisions are right for the individual of saying, I'm going to leave clinical care, I'm going to work in a non-clinical care setting, if every clinician does that, we're going to have nobody to care for us.
As Bianca mentioned, the Senate Health Committee has taken notice of this quite recently, and as we asked Senator Cassidy of Louisiana to actually make that video once he had those hearings take place in late February. To that issue, from a congressional standpoint, I'd like to ask each of you, what do you think the Congress or the U.S. government could be doing better at this point to help us deal with these shortage issues?
I'll try to chime in a little bit. At a really high level, it would be great for us to pay more attention to how reimbursement is really tied to the composition of our workforce and our ability to raise wages, because raising wages is not that simple in healthcare. You don't just pass along the increase in premiums. You don't just pass along the cost to the patients, except for through higher premiums, and we are trying to control the cost of healthcare. So it's just not that easy. So we have to think about the fact that Medicaid and Medicare are not quite reimbursing at quite the levels of commercial payers that allows then the ability to increase the wages as easily. So we need to first have that conversation at a high level of how is reimbursement structures affecting the way we pay our healthcare workers. But I think there are a lot of really interesting things being discussed right now, like just talking about the immigrants in our healthcare workforce. Right now there is some effort, some bills being proposed to think about how we can support immigrants who do come to the U.S. who may not be getting their ability to translate their skills that they had in their other countries into jobs that are equivalent. So people who might have been a physician in India, for example, they might come to the U.S., but they might take some time, and it's quite costly to get through the U.S. System to get licensure. Similarly, there's people who are nurses in other countries who come to this country, and they cannot pass through some of these barriers. And it's not as simple as just money. It's also having the time and availability. These people came to the U.S., they have other family commitments, and they have to have the supports that they need, not just financially, but also thinking about childcare supports that would allow them to go back to school and get the extra education they need to pass certain licensure exams.
Yeah, to add on, to start big picture, right? I definitely think we get what we pay for. And we have shortages in the areas that we have historically not paid for. You mentioned Medicaid, Medicare, mental health, long-term care, right? Like all these places that we have particular challenges are not surprising given what we pay for, right? And one of the things I really think about more and more in our healthcare system, particularly most recently, when we think about our direct care workforce and we think about what's going on with hospitals right now, I don't know if you've been reading about the boarding that's happening in emergency departments as they cannot get their beds open. Why can they not get their inpatient beds? Because there isn't the workforce in the nursing homes to be able to accept those, right? We're all connected. And one of the interesting things I think I also agree, physician workforce has seen a lot of investment, and we probably need to pay much more attention to our nursing workforce and our lower wage workforce, because ultimately, even for physicians, if I'm a physician who's just completely self-interested, if there is no nursing workforce, if there is no medical assistant, if I cannot get my patients out of the hospital, it will be miserable for me, and I will eventually leave, right? So what's going on now is just such a reminder of how we're really all connected, and we really need to be, I think, we need to focus on the places that we have not focused before.
I mean, healthcare it's hard work, and I think when we talk about the healthcare delivery system on how to fix it or the training, I think that we miss sometimes two big pieces. One is our healthcare workforce is changing. If you look at the AAMC data for medical students, we're 55% female right now in medical school about. And if you go upstream and look at undergrad, we have almost two young women in college for every young man, which will likely mean we're going to have more female physicians. When you look at applicants, there's actually significantly more female applicants than male applicants getting into medical school. We also have changing workforce expectations, which means the healthcare system has to change about how we recruit, how we retain, and how we set up systems. The importance of things like childcare are going to be very important, and the flexibility of work schedules. Yesterday, I was speaking with an executive from a very large integrated system, and he told me that 85% of all the primary care physicians are part-time. We're going to need to start to think about how we staff differently and recruit differently at all levels to get people to the workforce, because our workforce has different expectations about what they want, and we need to meet them where they are because they're the people we need to get into the healthcare workforce. The second trend we have is the healthcare consumer is very different today. They're much more informed or misinformed for the information that they can get. Healthcare has become much more political, whether it's the vaccinations, the masks, the Dobbs decision to gender-affirming care. We've got politics now entering the healthcare workforce. And frankly, Americans in general don't trust government and big systems. And coming out of COVID, there's even less trust in the healthcare system. So all this sort of ways that just makes it harder and harder to do the job of delivering clinical care.
Can I just, that stat, 85% of primary care providers are part-time, is so interesting. And I would love to be able to dig into that question of whether 85% are part-time because they cannot tolerate to be more than part-time. And if we could change staffing, for example, and create the space to be able to work full-time, but maybe with a little bit less workload so that you can deliver the care that you came to healthcare to deliver, right? It could look very, very different.
And for most of those physicians, I'm guessing it's part-time pay with full-time work.
Yeah.
They're still working 40 hours or more.
I'd say that is true.
So when I think about it, I think about both from sort of a supply and a demand side, and thinking about what it's the shortage comes from having too much demand and too little supply by definition. And so I think about the supply side, what Congress has done is essentially said we are going to increase medical residency slots. And what we do know is that supply is highly regulated, both with how many slots are available, and with what one can and cannot do as a provider across the spectrum. And so I think actually just one step before that, which is, can we get more funding for medical schools and nursing faculty? A lot of them get paid less than doing the nursing job itself, and so making sure that we retain faculty to train incoming physicians and incoming nurses, I think, is important. And on the demand side, which I know is not exactly the focus of this panel, but if you could reduce demand, you could also reduce shortages. If we could manage to somehow slow the number of multiple chronic conditions that our aging population has over time, we will also manage to kind of reduce the shortage that we're seeing.
And if I can also offer, we're talking about what's happening at a national level, but a lot of health workforce activities happen at the state level. And during this pandemic, there have been a lot of really interesting expansions to scope of practice that has been happening that has allowed people who are working in healthcare to really work at the top of their license. And so that means that many of our healthcare workers get trained to do all sorts of things, but state level restrictions might be in place restricting where they practice, what kind of services they can provide, what kind of patients they can see. And there's a lot of variability across states right now in terms of what different kinds of providers can do. And I think during the pandemic, because we were trying to increase the supply of workers, many of those scope of practice laws were really relaxed quite a bit. And now that emergency orders are being rolled back, so are some of those scope of practice restrictions. So they're being put back into place. And I think we need to do more to examine what benefit was there? Was there any benefit? I think there was certainly a sense that did help with some of the supply constraints, and I think we could certainly look across some of the states that were particularly innovative during this time.
And that's a plug to come to my talk tomorrow.
There you go. Sign you up, Phil.
Could you, on the front of the states that were doing creative things, which states were there? Just
I don't want to be too self-promoting. I mean, okay. The state's pretty good. No, Oregon also has been pretty good. There tends to be an alignment a little bit between political beliefs and where scope of practice tends to also be a little bit more relaxed. But I think the East and West Coast, you tend to find a little bit more openness in terms of the scope of practice that was being examined. But I don't know. Colorado also has, and just giving one more that's not on a coast, Colorado has always been somewhat innovative in their use of scope of practice laws.
The federal government did it too, with Medicare program and relaxing a lot of regulations that were effectively restricting scope and or requiring supervision in different situations, as well as doing things like paying for telehealth and paying then for not only video but audio telehealth, right? So a lot of things, it's kind of, I think about telehealth and I'm like, before COVID, it's like the three bears, right? We did a little too little. During COVID, we might have gotten pushed into a little too much out of like sheer desperation. And now the question is what's just right? I know actually Bianca works in this space, but with those regulatory flexibilities, whether you're at the state level, whether you're talking about Medicare, I think that same question, right? What were the regulatory flexibilities that went into place as a result of just sheer desperation, right? Yeah. Sheer desperation. But once they were lifted, hey, does that mean we can actually maximize our workforce? And so should we get rid of some of those more permanently? Yeah.
And the VA also has done quite a bit of that, especially relaxing scope of practice for nurse practitioners in particular, to allow more greater movement of nurse practitioners across different states, but also being able to maximize the use of them.
And I have to, Joanne's in the audience. Joanne is an expert on the nurse advanced practice nurses, but I think that the evidence, we're at 27 states and DC and Puerto Rico who have full scope, is that right?
Depends on how you count it.
How you define it.
Yeah. Yeah, but for advanced practice nurses, right? I mean, we're over the hump, right? And the evidence suggests that the quality of care is well maintained, and then on top of it, full scope states, nurse practitioners have a tendency to practice more in more rural and underserved communities. I think that's me quoting Joanne's research.
Costs go down, so physicians benefit too, less malpractice costs.
Going back to rural communities, which I know they touched on in panel one, so we have a mismatch in training in this country about where we train all of our healthcare workforce and where those people work and live. So in 2021, the National Academy of Science, Engineering, and Medicine had outlined the roadmap for high-quality primary care for the United States, and we know that primary care can save healthcare dollars if implemented appropriately. In that roadmap, one element of that plan was to implement a way to measure and annually account for primary care and where primary care is being delivered. Part of that was specifically talking about rural communities and how we are not training people in the rural communities, we are training them in the urban settings, and then as the programs last longer and longer, people are living in the communities where they train. I'll open this up to everyone, but can you speak to a little bit about, how we can start to change that system and be better about training in the rural communities, that we have people retaining their practice in the rural communities?
I think Michael has some interesting thoughts early on.
Well, I mean, it's tough to, when you think about underserved populations, you have both rural and urban, and while they're both very difficult to recruit, I would argue personally that it's harder for rural because you need to live in the rural community. In an urban community, you may have options to send your kids to private school, but I've talked with a lot of physicians who love doing the work, but when they have school-age children, struggle with the realization that the school systems aren't good. And what does that mean for their child's future? Even though they love the work, they love the rural community, but they realize that that's difficult for their own families that they're going to have. So, then they move away. Hopefully they can come back later. But what we can do to recruit people from their community, whatever community, urban or rural, get people from the community opportunities to get trained and serve their communities, I think will be better served.
Where clinicians also do their residency also matters quite a bit. At University of Washington, we have what's called the WWAMI program for short. It's Washington, Wyoming, Alaska, Montana, and Idaho. Sometimes we add O, Oregon, so WWAMI-O or WWAMI. But anyways, the idea is that many of the students are being recruited from one of those 5 states, and they do their 2 years of undergraduate training at University of Washington, and then they return back to their communities. And that's worked pretty well, but my colleague Sue Skillman in particular has been studying kind of whether education in a rural area matters versus residency in an area matters, and it seems like residency really is a bigger predictor for whether or not someone will stay in a rural community. Some of it is again creating the attachments to the community at that time of their life. Some of it's having more exposure to what it means to do rural practice. And actually, at University of Washington, in the School of Nursing, we have a program that's funded through Premera, like the health insurance company, who wants to see more nurses practice in rural areas, and we're experimenting with a rural training program where nurses don't really like the term residencies because their belief is that once they finish their education, they're done and they're ready to practice. But they are trying to provide a 1-year additional fellowship post MP training where they're having rural opportunities and try that out. And we're studying whether or not that's having a lasting effect at keeping nurse practitioners in those areas. Again, exposure is a big part of the equation, but also making sure that there are the systems in place in those communities that support individuals is important. Because I can hear from some of the interviews that we've been doing with those nurses is that they're saying things like, well, yeah, I practice in the rural area, but I live about an hour away because my partner really needs a job, and that job is another hour away. So we split the difference between the 2 communities.
Can I talk about a program that actually is
Please.
is a federal program to address
Please,
this?
yes.
So there is, and actually Senator Cassidy, he kind of spoke very quickly, but he mentioned something called the Teaching Health Centers program. The Teaching Health Centers program, let me take a quick step back. The public makes a very big investment in the training of physicians, largely through Medicare graduate medical education payments that are highly tied to hospitals. Medicaid, GME, puts out a combination of state and federal dollars. And then and in total, as well as the VA actually, about $20 billion annually going out to teaching hospitals on an annual basis to support the training of largely physicians. And the Teaching Health Centers program was created in the Affordable Care Act in response to the fact that that money is largely tied to hospitals, and so and defined in statute with certain formulas, but really with unfortunately very little requirements or accountability around what kind of specialties are trained. And so, what do teaching hospitals do? They produce a workforce that's ready to staff the hospitals of America, right? Not surprising. And so the Teaching Health Centers program was created in the Affordable Care Act in contrast to say, one, the money cannot go to a hospital and it actually can't go to a medical school. It must go to a community-based outpatient setting. And the vast majority of the teaching health centers, they have to be in primary care, are in community health centers. And about 20% of them, I think, are located in rural communities. And they are producing primary care doctors who go into rural communities and who go into underserved communities. And I will just reveal that I was on an evaluation and went out to site visit one of these teaching health centers. It was in West Virginia, and they were genius because they had a barbecue at the end of the day, and they sat us down with their teaching health center residents, and I sat across this very lovely young doctor who told me that she grew up about an hour outside of a small town in West Virginia. The teaching health center itself was located in a rural community, and she grew up an hour outside of that community. She said, I went to the College of Osteopathic Medicine in West Virginia. I got very good grades. I could have gone anywhere I wanted to, but this is home. And in between the end of the clinical day and the barbecue, she had gone home, and sitting in her lap is her 9-month-old baby. She married her high school sweetheart, who still worked in the bar an hour away, right? Like, I know that's one story. The numbers show that it works. But teaching health centers, which are about to come up for reauthorization and refunding, are funded at $126 million a year versus $20 billion a year, right? And so we could be much more intentional about our investments.
Sounds like an advocacy opportunity for all of us to think about. Any additional comments? Go ahead, yeah, please.
I think it was mostly covered. I will say, what Candace said earlier, what we pay for, we get. But it also matters what we're actually paying for. And I think there's some incentives out there that don't work as well as others. And we heard some on the previous panel being discussed. And I think it's important to evaluate, like, are we using debt forgiveness or higher payments that are maybe tied to RVUs or services provided, or something else that might be more effective? If you were looking for money for more effective programs, you might consider shutting down the ineffective ones.
Ooh. Ooh.
I'm going to turn now to workforce diversity. So this has been obviously a topic that I think is near and dear to all of us as we try to diversify our workforce. But I'd like to ask each of you who'd like to comment, what do you think the best work we can do is to help continue to diversify our workforce?
Start over there.
Sure. I mean, we need to continue to recruit from diverse communities. And that means we've got to go further upstream to high school, maybe even earlier upstream to that, to get people excited by science, get excited by healthcare professions, and offer those opportunities to get trained in those roles and find those career options for them. In the last number of years, the AMA, which we're based in Chicago, we've decided to really start to think about Chicago as our home, as opposed to just being our home base as a national organization. And we've been investing in the West Side, which has a 10-year life expectancy difference than the North Side of Chicago. Literally a decade. If you live 10 miles, the average life expectancy is over a decade. And their West Side's goal is to close the life expectancy. That is the mission of the goal. But we've been working to help people in the community there through the formal initiative called West Side United, and giving small business grants, but also working with the community college, Malcolm X Community College, to get training programs for medical assistants and other type of assistant roles. And it's not just about giving a young mother a scholarship to go to the program. You need to give the young mother a stipend to get daycare so she can go to the program, and making those investments in the community, and doing that like in the West Side where the training program is. It has the double benefit of recruiting from the community, but investing in that community as well.
So one thing I like to talk about usually when we look at the healthcare system, which has about 17 million people, that's about how many people work in healthcare, give or take a couple million. And as a whole industry, the healthcare industry is actually similarly situated in terms of racial and ethnic diversity as the rest of the economy. we tend to have slightly less representation of Hispanic healthcare workers relative to the rest of the country. But it really varies in terms of setting and the kinds of jobs where we see that diversity. We see the most amount of diversity really among our aides and assistants. That's where about over half of them are non-white. And we could do more to make sure that that is spread across by thinking about those pipeline programs. And I think the other panel did a nice job talking about some of those issues, which is it's not such an easy thing to just jump from a home health aide to, say, an LPN or an RN. That takes time away from work, which costs money for people. People have children they have to take care of. It's not such an easy endeavor, but on top of that, we actually need people in those jobs. We need to keep them. We actually need home health aides. We need nursing assistants. We don't need them all to leave these jobs to become RNs. So we have to do kind of two things. One is to make sure that those who are in those agent assistant positions actually have opportunities to move up if they want to. But then we have to then look at some of the higher educated jobs and say, well, why aren't we getting the pipeline of people that we need that reflects the populations that they're caring for? Because that's really important. I think there's a number of studies that are starting to come out really showing how the diversity of the workforce, of the health workforce, of the physician workforce oftentimes, actually has a real impact on the care that the patients receive. I mean, we're starting to see more studies like that because the data are improving. We have a really hard time connecting the actual healthcare worker to the patients that they serve. There are just limited data sets that allow us then to look at the racial and ethnic composition of both the workforce alongside the actual patients. But the limited evidence that's starting to show up suggests that it does matter. Now, however, I recognize that, so if it doesn't always work perfectly, that concordance. And one story I like to tell sometimes is that my mother is Japanese, and she's an immigrant, and she was paired with a Japanese male physician who was really born in America. And I don't know that I would say her care was all that much better just because she was paired with another Japanese person. In part because I think the issue at hand was a little bit more focused on the immigrant piece of her background, one of which is a language barrier. I mean, while she has been in this country for some over 40 years, her English is still relatively rough, and she has a hard time sometimes understanding issues as quickly because the words are kind of complicated for her. And so what I recognize is the importance that we have to also teach our providers how to have that cultural humility, how to give them that cultural competency to address a diverse workforce, because we're not always going to get that one-to-one concordance.
And I think that there's very little, but some suggestion that diversity itself might help with those things, right? That there's just a few studies that suggest that, and many of these studies are in the physician workforce. But when medical students have positive exposures to faculty and peers who are Black African American, and another study, same group, looked at positive exposures to LGBTQ plus faculty and peers, right? And then you implicit bias test them, that they test better on implicit bias. I mean, it's two studies out of the same group, but again, that idea that diversity itself might be part of the solution. I actually also think that we have a rising, coming out of COVID, right? We have a rising problem with trust, and I think parts of our society having a lot of distrust in healthcare system for very legitimate historical and current reasons, right? And one of the things I think about a lot is that when the physician workforce, which is a labor opportunity issue, right? But when we so obviously do not look like the population, right? And we're not even making progress on this. Why would anybody look at us and trust us, right? And go, oh, that's obviously going to be an unbiased workforce, right? So it's just, there's so many reasons to do this. And to do it, I think we do need to go back and we need to be critical. We need to be critical about where is the bias and discrimination happening in who we recruit, how we do our admissions, right? How we support people through the pipeline, where we're discriminating within the pipeline, because we are. The evidence is showing us that we are, and we need to do the hard work of really, really unpacking that, and it is going to be really hard work.
So I agree with a lot of that. The one thing that I would say is, for me, in my perspective, the pipeline's important, and that's kind of where you have to start. The issue with you having faculty that look like you, train you, is it's a hard place to start because there simply aren't those types of faculty out there, and then you place the burden on the 1 or 2 faculty that look like you to train you, and it's a lot to ask of that person, and it's essentially a tax. And so really what we need is, I think, more to enter the pipeline to be able to support, I think, a more diverse healthcare workforce.
And I know we spoke a little bit about the pipeline and then the last panel, and I guess I'll open it up because maybe it does need to go back to preschool, but where do we need to start working? We certainly at the graduate school level, we try to do that work, and we look back and say, no, it needs to be undergrad and high school and beyond. What are your thoughts on how we really need to change the system?
That's a big question. It goes back to fixing education in America. I mean, there's a lot of, way we fund education through property tax, which means, there's disparate investment in our schools, to the increasing cost, as someone who's got 2 high school seniors, the increasing cost of attending college makes it very difficult if you're low-income family to send your kids to college. I mean, there's so many sort of structural issues that we have to think through to start make education sort of something that's accessible for everyone.
I think the other thing is we could certainly do a lot more to look at the retention issue and just make sure that we're not losing the workers that we currently have. Jeanette and I wrote a paper a year ago looking at turnover among healthcare workers and really looking at those who are leaving into a state of being unemployed or out of the labor force rather than job switchers. And what we did see is that during the pandemic, but even starting before the pandemic, our Black and Hispanic workers are leaving their jobs at a higher rate than our white healthcare workers. So why is that happening? And this probably goes back to issues of burnout and kind of the stresses that they're feeling on the job. It could also be related to pay, and that maybe other industries are providing them better opportunities. I don't know the answer to that, and certainly that's an area for us to explore more. But I think at least for the diversity piece, we could certainly do more to at least make sure that we're not losing our workers of color disproportionately.
I think having better data, as you had said before, will also help us understand exactly how to improve our existing workforce's interaction with a more diverse population. I don't think we fully know because there's a lot of anecdotal evidence, and it's hard to figure out which of these anecdotal pieces are the most important pieces. And if we had more data on that, that would be helpful.
One of the things that I've been just scratching my head with about the last year or two is the corporatization of healthcare. We had there's the big 4 or 5 insurers, United, Anthem, Humana, Cigna, and which one am I missing? But they tried to merge, and of course they weren't able to do it because the government can really look at market share of 2 insurers merging in a community and say, well, that's going to be antitrust. So they've now all moved to vertical integration. Anthem is now with CVS. They buy the home health agency. They have the PBM. United's got Optum, which is the largest employer of physicians in the country. 75,000 physicians work under the Optum umbrella. That's larger than Permanente. And then you have Amazon buying One Medical. You've got Dollar General now getting into healthcare. You have Best Buy who wants to use their Geek Squad to help provide techs for home health. This all could be very positive, but this also could be very negative as healthcare becomes more fragmented. So are these for-profit companies, let alone venture capital and private equity who are buying up practices, going to skim off certain levels of care and leave other types of care, whether that be the harder care or certain patient populations, to others that care for? Some research that we looked at those practices that are being acquired tend to be more higher profitable practices with less diverse patient populations. So it'll be interesting how all of this pans out. It could fizzle, as many realize that healthcare is hard. But it's interesting to see these new corporate entities getting into healthcare.
Well, one of the trends that we're also seeing with that is that physicians now. The other health professions, but physicians are increasingly becoming employed, right? Within the last 2 years, I think we went over that kind of 50% mark,
2018.
Which then brings up the question of what is going to happen and how is the workforce going to respond to things like increasing corporatization, maybe decisions that are being made that might be seen as profit over people or politics over people. And I want to talk about unions. Physicians are 5 to 6% unionized. I think nurses are maybe 17% unionized. But we're seeing a rise in organizing and in strikes. But one of the really interesting things I think that we've seen with when the KP mental health workers striked within the last year, when the nurses striked in New York, generally the wage and the income issues were settled. It was about staffing, right? And that inability to provide the care that they knew that needed to be provided because there was not enough staffing. So it's really interesting, and I'm not saying that unions are the absolute right answer, but I definitely think that one of the answers to burnout and moral injury is organizing and empowering workers to be part of the solution again, whether that's in a formal unionized setting or if that's a more informal way.
I think there is a way, though, not to pit the workers against the organizations, for them to actually create an incentive for it all to work together. And this is where I see payment for population-based health working, and we kind of talked about this a little bit. It's not there yet, but if you could incentivize both the firm, the organization, and the workers to both care about, together, jointly care about how well patients do, not just do they show up to my office and have I taken care of whatever they need when they're in my office, but really their patient health over a course of time. I think that can help, address many of these concerns. And I think the other thing, too, what we see with accountable care organizations, which is one of these mechanisms for population-based payment, is that you can also incentivize organizations to care more about diverse populations by setting benchmarks of spending, higher, lower, high. Making it more generous, or more, in some sense, providing more funds for these organizations to care for sort of a more diverse population.
Well, I think we're going to open it up to questions now, to the audience. Yes. Thank you all for all of your answers so far. There's a couple of other topics that we may not get to, burnout and some other issues, but please go ahead.
Thank you for being here. My name is Brad. I'm a third-year medical student at the School of Medicine. I had one thing that I wanted to share from a conversation and then a question. So I'll start with the thing that I wanted to share. When we were discussing residency programs being in rural areas, I wanted to share that my understanding that there's one, maybe two residency programs in the state of Alaska. And I did my family medicine rotation in Nome, Alaska. And most of the attendings that I worked with there were that had lived and built their practice at this hospital were graduates of this what's called AKFMR. Mm-hmm. So just for your research, I don't know if you know that, but I think that it's an N of like 10, but
10 very important providers, yeah.
So that's one thing I wanted to share. My question is on a different topic. Much of the American healthcare system is held up by in my mind, exploitation of the exploitation and underpaid labor of resident physicians. PGY1 residents at Tulane get paid $57,000 a year, and many work like 80 hours a week. That results to like $13 an hour. Why do we, in our country, pay such highly trained physicians so little? And how can we move towards a more fair wage for these residents that are working really, really hard to provide care to our communities?
I was going to say American Medical. No, I'm kidding.
I'd like to pay you more, Brad.
I might. There's a study in Health Affairs that looks at trends of salaries of occupations over time, and they look at doctors and lawyers and the whole gamut, and business school graduates. And what's striking about that is that physicians earn the most in terms of lifetime salary than any other occupation. And it's not by a small margin, it's by a huge margin. And if there could be a way of income smoothing so that it's not such a low wage at the early sort of start of your career, but you can actually, and then like a huge jump, it's valuable to have money early in your career because you need it. Economics is all about sort of consumption smoothing. I think that could be one way of getting at it.
And I'll say, I do want to validate, I understand it's a real concern, and I've heard that said of our family medicine residents, particularly when they compare their work compared to their fellow nurse practitioners, where they're feeling like they're paid quite a bit more. But I think that the challenge is seeing that long-term picture, not to say that it's okay to exploit people at any point in time in their careers, and certainly I do think this goes back to how is our medical system funded generally, and so we have to go back to GME and how we pay for that. So Candace.
Well, I wasn't going to say GME. The interesting thing is Medicare is on average paying $175,000 per FTE on average, though. So there will be more and there will be less. So interestingly enough, even for a 3-year residency program on an average of $175,000, we're talking over $400,000 of public investment in the training of one provider, right? And this is now me wandering off, but a couple years ago, there were all those TV shows about plastic surgeons. And I happened to go to medical school with one of those plastic surgeons, and I was like looking at the webpage, and there was 3 of them. And I just calculated how much those 3 people represented in public investment. It was, I can't even remember, but it was over $1 million, right? Probably close to $2 million for 3 of them in a 6-year plastic surgery residency, right? So there's definitely issues with our Medicare GME. But one of the things I always think about with residency is how much is it the income and how much is it the culture and the environment in which you are working, right? And that thing that you're describing of 80-hour work weeks, very little, and the culture, I've done it, right? The culture of residency is you be quiet, you do your work, right, and you don't complain, right? And then in the environment of hospitals where everybody is getting burned out, right? And so we drop our residents into that setting with the unspoken, don't make waves. You only got 3 years, 5 years, 6 years, whatever, just get through it, right? So I think that there's an overall reckoning inside of our healthcare systems of nobody should be suffering like this. Now, it's very hard. It's going to be very hard to undo this culture. That culture is like, ugh, right? Like, I don't even know how long to put that culture at, right? But again, it kind of gets back, for me, it gets back to we're all connected. Burnout and moral injury, we have to change the environment because we're burning out medical students, right? And then the residency just is on top of that. And we're just losing people left and right now, right? So there's actually your issue, I think, is embedded in a much bigger issue.
And if I could just add, I think one of the challenges, and I'm sorry if I missed what specialty area you're going into, but certainly for primary care residents, they are certainly looking around themselves and saying, is this worth it? My plastic surgeon peers are getting paid so much more. Why am I going to suffer this much to not get that payoff in the end? That is a real concern that we have to address.
And you see it in the clinics when you're trying to encourage trainees to do these fields that need physicians, but they're seeing their mentors burning out at their desk. It's very difficult to convince them that this is the field they should go into.
And I would also add, it's not just what you walk home with, the pay that you walk home with, right? When certain areas of healthcare are paid less, the whole team suffers. Right? I was super fascinated by one of the HRSA reports looking at physician assistants. You know who loves to hire physician assistants? Orthopedic surgeons, right? The first place I was exposed to as a pediatrician to a nurse practitioner, the NICU, neonatal ICU, right? The places that are reimbursed better are able to fill out their teams, right? And support practice in different ways. So it's not just what you take home at the end of the day. It's the environment, ultimately, that you practice in, too.
Hi. During the Senate Help Committee, it was brought up, and I don't have a source for this, but the speaker from Johns Hopkins was talking about how 90,000 nursing school applications are turned down every year, and so her argument was that this is a faculty supply issue more than anything. So I was just wondering if you have any thoughts on that or any solutions on that side of the equation.
Yeah, so that was Dean Stanton. She was the dean of the School of Nursing at Johns Hopkins who said that. And I think there are many factors that lead to shortages, but the nursing faculty shortage is a real one. And a big part of that is, I think Alice, I think you might have mentioned it earlier, is a pay differential. I mean, faculty are not super well paid, including nursing faculty. And the hospitals certainly pay a much better wage. And so to take basically a pretty big pay cut to work in a school of nursing as a faculty member, it can be tough. And I mean, we can certainly go more into the politics of academia too and what we reward and whether or not nurses might be even treated fairly even as faculty members within an academic institution.
Yes. So I don't know the nursing literature as well as I know the physician literature, but if you look at it over time in terms of the number of applicants we have relative to the number of medical school spots and the number of physicians we train from like the 1950s onward, the applicants has always been higher than what we have spots for. And what you see is applicants increase when income increases, not all that surprising, but that's not the limiting factor. The limiting factor is slots. And the slots increase when medical school funding increases. And so I would imagine that sort of works in a similar way for the nurses, though I could be wrong. Yeah. So it would, I would think, really come down to funding for schools.
And then I'll just say one other limiting factor, and it's not just for nurses, but it's actually for pretty much all professions right now, is the lack of clinical placements and training sites. I think COVID has certainly restricted that considerably because we didn't want people who were not directly caring for patients on the floors, in part because that was taking time away from the practicing providers who could provide care for patients with COVID. But even pre-COVID and now kind of as we're coming out of COVID, funding clinical placement sites, that's a significant investment. I don't know the numbers around that, but that is time away from somebody providing care for somebody to now train somebody else. Mm-hmm. And that's not a cheap endeavor. And not just like I think the last panel might have talked about, like who trains physicians to be leaders or nurses to be leaders or academics to be teachers. I mean, it does take some skill to also know how to do precepting.
Which goes back to what I think is the biggest challenge of the workforce shortage is not figuring how to increase the pipeline because it's basically dollars and it's a fixable solution. We might not be fixing it, as we talked about, but it's keeping people who we've trained from burning out and deciding that they don't want to be involved in clinical care. And that's really hard. It's a systems issue. We talked about patience and disrespect. I'll present a paper tomorrow about discrimination and inappropriate behavior by patients to physicians. Obviously, if you're a female physician or a minority physician, you're more likely to experience that over your male counterparts. We have data that I'll show tomorrow. We have an issue of time. How much time you're actually spending seeing patients, which you're trained to do, you're passionate to do, versus time on the EHR doing documentation, dealing with prior authorization, dealing with other bureaucracy that doesn't necessarily improve clinical care, doesn't improve patient outcomes, but that's the backbone of morass we've built in this U.S. healthcare system.
So we got time for one more.
Oh, one more question. Okay.
Hi, thank you so much for being here. My name is Claire. I'm a medical student going into family medicine. My question is
Yay. Thank you.
And Dr. Newby's my preceptor this
She's
week.
actually
so thank you for
right now. Yes. All right.
Good model right here.
But so I wanted to kind of continue a little bit of what you alluded to about what is the role of the future of the primary care physician. So I am from a really rural area, and my close friend from high school went through the nursing route, and she is now 2 years into being a nurse practitioner, full practice, is like the primary care provider to a lot of our friends' kids, and that's amazing. And I am looking here like, oh my God, I still have 4th year of medical school and 3 years of residency, and both on like a burnout perspective and in like a public investment perspective, I am the least efficient way to make a primary care provider, you know? So what is the role of the primary care physician when nurse practitioners do so much amazing things and they're kind of also the future of the specialty? Yeah.
But I think education matters. I mean, a nurse practitioner can do 2 years of school and 500 hours of clinical care. That 2 years of school may not even all be in person. You're going to do 4 years of medical school and 10,000 hours of training, which means on day one, you are ready to see patients. What that nurse practitioner is doing in their early career is they're basically going through the residency. They're learning on the job. And so there's some recent research from the VA of nurse practitioners versus who can practice without physician oversight versus physicians. They're more likely to order more tests and do more screening because they're less confident earlier in their career. So they're doing their residency almost in on-the-job training. But I would say that medical education is still important, and what you're doing is still important, and that training you have will set you up very well to provide excellent clinical care. And thank you for going to family medicine.
Maybe one thing I can offer is that there's a lot of work to go around.
Yeah.
I
That's
actually
true.
think it's a little bit too bad that we do have a kind of a pitting of one profession against another in any of it. I mean, we talk a lot about the physician versus nurse kind of fights, but this happens actually across many other occupations where we're asking, like, who should be doing what? And I'm looking around like, all of it. All of you should all be doing this work. This is not should just not be just one or the other domain. But I do think that the medical profession probably has to do some more deeper thinking to say, what is the value of education? Rather than like nibble around the edges of like, oh, I can do this better than you. Like that's not, I don't find that to be a very productive conversation, because I do think there's a lot of work to go around. And I do think that what I think I'm hearing from students and residents like yourself is asking the medical profession, help me figure out the value proposition of my education. And that is what's not really happening. Yeah. And I think the challenge I can see, especially medical education, but I think this happens again across multiple health professions, is that we don't really prepare medical students to be prepared for the health system in which they're about to work in. I think the comment was made earlier that where's the health systems course that you get? I mean, I've lectured to medical students, and I had students come up to me and ask me, so you talked about Medicaid. Where am I going to learn about Medicaid? And I'm like, I don't know. It's not in your curriculum. Residency. I mean, I say this so facetiously. You learn on the job, but you're learning it during your residency program. And I say, no wonder you're getting burnt out, because you're not really quite prepared for the complexity, really, of the health system. But you're certainly smart enough to know that. And in some ways, I think we have to figure out how to add those additional skills in there so that you can be a particularly excellent professional and be prepared. So I can go on about this for a long time, but I say thank you for going to family medicine, but you're going to be providing a different kind of contribution probably to the care of your patients than nurse practitioners, but I think everybody is in there trying to do their best caring for the patients that they can.
I just want to echo that. I think that there is a lot of professional infighting, and I am concerned that one of the side effects of that is that it distracts us from actually asking that question of what are the right teams? What are the right supports? In what situations do you need something different, right? And in rural communities, right, there might be a decision that I actually do need a fuller scope, right? And that might lean towards a physician. It might not. Right, and those questions you make a really good point. What's the value of my medical education? Right, those questions remain a little bit unanswered. I think because we are a little bit distracted with just that, like, and Bianca's right. Like, it's not just between physicians. Actually, Joanne brought up those dental therapists, yeah. Right? Like that is hot, right? Yeah. That's a hot area. But nurses and medical assistants, right? And we see that. Then echoed in scope for medical assistants in different places, right? There is fighting, and I think the challenge is that we don't let it distract us from asking the actual hard questions of what should our teams look like? How do different situations need to be taken into account to mitigate that? I will also say that I think that, and I don't want to not recognize this, I think that we've seen things like as private equity is buying out healthcare systems, that over time there's a change in the staffing. That might be perfectly good, right? To maximize access and maximize care. But I think that there's also a fear that are those choices being made to maximize profits, or are they being made to maximize quality? And how do we make sure that we create accountability to make sure that quality is at the center of all of that, all of those decision making, and that we kind of bring everybody together. And I think that, and I also just want to recognize that I think as physicians are watching this happen, are seeing their peers being replaced, the sense of being replaced by a nurse practitioner, that it's incredibly jarring, right? So I don't want to not recognize that people are, it's that difference between population health and individual level things, right? Like, it is jarring, it is distressing, right? But at some point, the question is how do we maximize access and quality and think about cost, right?
Well, and with that, I want to thank all our panelists today. If you thought this was enticing, please join us tomorrow for all of their research presentations. And we are going to take a quick break and then move to our fireside chat. Thank you, everybody.
Thank you.
Thank you.